Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 291 of our pharmacotherapy series, which majors in heart failure. The first question reads, JAJ, a 58-year-old man, is admitted with a chief complaint of increasing shortness of breath and an 8-kilogram weight gain. 2 weeks before admission, he noted the onset of dyspnea on exertion, abbreviated as DOE, after one flight of stairs, orthopnea, and ankle edema. Since then, his symptoms have worsened. He has also noted episodic bouts of paroxysmal nocturnal dyspnea, abbreviated as PND, and he has been able to sleep only in a sitting position. JAJ reports a productive cough, nocturia that is 2 to 3 times a night, and edema. JAJ's other medical problems include a long history of heartburn, a 10-year history of osteoarthritis, depression, and poorly controlled hypertension. A family history of diabetes mellitus is also present. Physical examination reveals dyspnea, cyanosis, and tachycardia. JAJ has the following vital signs: BP of 160 systolic, 100 diastolic, pulse of 90 beats per minute, and respiratory rate of 28 breaths per minute. He is 5 feet 11 inches tall and weighs 78 kilograms. His neck veins are distended. On cardiac examination, an S3 gallop is heard. The point of maximal impulse is at the 6th intercostal space, 12 centimeters from the midsternal line. His liver is enlarged and tender to palpation, and a positive hepatojugular reflux is observed. He is noted to have 3+ pitting edema of the extremities and sacral edema. Chest examination reveals inspiratory rales and rhonchi bilaterally. The medication history reveals the following current medications: hydrochlorothiazide 25 mg every day, ibuprofen 600 mg 4 times a day, ranitidine 150 mg every night at bedtime, and citalopram 20 mg every day. He has no allergies and no dietary restrictions. Admitting laboratory values include the following: a hematocrit of 41.1%, a white blood cell count of 5,300 per microliter, sodium levels of 132 milliequivalents per liter, potassium levels of 3.2 milliequivalents per liter, chloride levels of 100 milliequivalents per liter, bicarbonate levels of 30 milliequivalents per liter, magnesium levels of 1.5 milliequivalents per liter, fasting blood sugar levels of 100 mg per deciliter, uric acid levels of 8 mg per deciliter, blood urea nitrogen of 40 mg per deciliter, serum creatinine of 0.8 mg per deciliter, alkaline phosphatase of 44 units per liter, aspartate aminotransferase of 30 units per liter, B-type natriuretic peptide, abbreviated as BNP, 1364 picograms per milliliter. The normal value is less than 100 picograms per milliliter. He has thyroid-stimulating hormone levels of 2.0 microunits per milliliter. The chest radiograph shows bilateral pleural effusions and cardiomegaly. So my question to you is, what signs, symptoms, and laboratory abnormalities of heart failure does JAJ exhibit? Relate these clinical findings to the pathogenesis of the disease and to left-sided or right-sided heart failure. Left-sided ventricular dysfunction primarily causes pulmonary symptoms, whereas right-sided ventricular dysfunction causes signs of systemic venous congestion. Although left ventricular failure usually develops first, many patients present with signs of biventricular failure. Let's briefly look at left-sided heart failure, also known as left ventricular dysfunction. Weakness, fatigue, and cyanosis result from decreased cardiac output and compromised tissue perfusion. If the left ventricle is not emptied completely, pulmonary congestion occurs. Dyspnea, that is, labored or uncomfortable breathing on exertion, a productive cough, rales, that is, crackles in the lung during auscultation, pleural effusions on chest radiograph, and hypoxemia all result from pulmonary congestion. Pulmonary symptoms are aggravated in the reclining position. Orthopnea or shortness of breath in the supine position is quantified by the number of pillows the patient must lie on to sleep comfortably. JAJ, for example, could sleep only sitting upright. Paroxysmal nocturnal dyspnea is characterized by shortness of breath that awakens the patient from sleep and is alleviated by an upright position. Cardiac dilatation is observed on chest radiography as an enlarged cardiac silhouette. The point of maximal impulse corresponds to the apex of the left ventricle and is visualized as an external pulsation on the left side of the chest. It is displaced laterally and downward from its normal location at the fifth intercostal space, less than 10 cm from the midsternal line. An S3 gallop rhythm denotes a third heart sound often heard in close proximity to the second heart sound, closing of the aortic and pulmonary valves, in heart failure. Rapid filling of the ventricles causes the S3 sound and, in an adult, usually indicates decreased ventricular compliance. In patients with mitral valve regurgitation, an S3 heart sound is common and denotes systolic dysfunction and elevated filling pressure. Tachycardia is caused by compensatory increases in sympathetic tone. Weight gain and edema reflect sodium and water retention resulting from decreased renal perfusion. See pathogenesis section. As renal blood flow, abbreviated as RBF and GFR, decrease, a disproportionate amount of blood urea nitrogen may be retained. This phenomenon is termed prerenal azotemia and is detected by an elevated BUN to serum creatinine ratio of greater than 20:1. JAJ has a ratio of greater than 40:1. Pre-renal azotemia also can be caused by dehydration and overuse of diuretics. Frequency of urination at night, that is nocturia, is caused by improved perfusion of the kidney when the patient is lying down. We will now talk about right-sided heart failure, also known as right ventricular dysfunction. The signs and symptoms of right ventricular dysfunction are related either to hypovolemia, valvular disease, or pulmonary hypertension. The overall effect is elevation in central venous pressure. Dependent edema results from increased venous and capillary hydrostatic pressure, causing a redistribution of fluid from the intravascular to interstitial spaces. Ankle and pretibial edema are common findings after prolonged standing or sitting because fluid tends to localize in the dependent portions of the body secondary to gravitational forces. Sacral edema can be present in patients at bed rest. Edema is subjectively quantified on a 1+ that is minimal to 4+ that is considered severe scale. JAJ has 3+ pitting edema. hepatomegaly, hepatic tenderness, and ascites, that is, fluid in the abdomen, arise from hepatic venous congestion and increased portal vein pressure. Metabolism of drugs highly dependent on the liver for elimination can be impaired by both the retrograde venous congestion of the liver from right-sided heart failure and the decreased arterial perfusion of the liver from left-sided heart failure. Congestion of the gastrointestinal tract makes the patient anorectic. Neck vein distension, primarily seen as internal jugular venous distension, denotes an elevated jugular venous pressure. How high the neck veins are distended while the patient is lying down and how much the patient's head has to be raised before the jugular venous distension disappears gives the clinician a rough estimate of the patient's central venous pressure. Jugular distension in centimeters is measured as the vertical distance from the top of the venous pulsation down to the sternal angle. Neck vein distension of less than 4 centimeters when the patient is lying with the head elevated at a 45-degree angle is considered normal for an average, healthy adult. Applying pressure to the liver can cause further distension of the neck veins if hepatic venous congestion is present. This phenomenon is termed hepatojugular reflux. The next question reads, does JAJ have left ventricular systolic dysfunction abbreviated as LVSD? Shortness of breath, crackles on auscultation, neck vein distension, edema, and nearly all of JAJ's other signs and symptoms provide some important clues about the nature of the underlying cardiac abnormalities. However, they are limited in evaluating structural abnormalities. Some of these symptoms can be confused with other disorders, especially reduced exercise intolerance, which is often a gradual process that patients may fail to recognize and report. An enlarged heart on a chest radiograph increases the suspicion of left ventricular systolic dysfunction, but this finding can be absent in some patients with left ventricular systolic dysfunction and present in others with normal left ventricular function. Some patients may be asymptomatic with structural abnormalities. The most useful method to diagnose heart failure with left ventricular systolic dysfunction is by measuring the left ventricular ejection fraction abbreviated as LVEF. All patients with suspected heart failure should have an ejection fraction measured before beginning therapy because the treatment strategies between heart failure with reduced ejection fraction abbreviated as half-ref and heart failure with preserved ejection fraction abbreviated as half-PEF differ. Two-dimensional echocardiography coupled with Doppler flow studies Doppler echocardiogram is the diagnostic test of choice for measuring ejection fraction. This procedure uses sound waves to visualize and measure ventricular wall thickness, chamber size, valvular function, and pericardial thickness. Ejection fraction is estimated based on changes in ventricular chamber size between diastole and systole. This method of ejection fraction measurement is not as technically accurate as that provided by ventriculography, but the procedure is more comfortable for the patient and the correlation of the measured ejection fraction to that of the other methods is acceptable. Radionuclide left ventriculography, also called a multiple-gated acquisition scan, uses radio-labeled technetium as a tracer to measure left ventricular hemodynamics. Although this method is the most accurate measurement of ejection fraction, it is moderately invasive because it requires venipuncture and radiation exposure. In addition, radionuclide scanning does not provide information on the architecture of the left ventricle. Magnetic resonance imaging and computed tomography are useful in evaluating ventricular mass but do not provide ejection fraction data. Subsequently, JAJ underwent an echocardiogram. The results were reported as left ventricular hypertrophy abbreviated as LVH with mild to moderate depression of ejection fraction that is, 30% to 40%. Because he has systolic dysfunction and classic congestive signs, he fits the criteria for having congestive heart failure. The next question reads, what stage of heart failure does JAJ exhibit according to the ACEIs criteria? How severe is JAJ's disability according to the New York Heart Association functional classification of heart failure? Because JAJ has symptoms of heart failure and structural changes in cardiac architecture, he is in ACEI stage C. On admission, JAJ is in New York Heart Association functional class 3 as evidenced by a need to sleep upright and an inability to undertake even minimal physical activity. It is important to recognize that heart failure can progress very slowly in some patients and very rapidly in others. A patient with MI could move from stage A to stage C. The next question reads, what factors contributed to the cause of JAJ's heart failure? Age, hypertension, MI, diabetes mellitus, tachycardia-induced cardiomyopathy, valvular heart disease, and obesity are well-established major risk factors associated with the development of heart failure. Other risk factors associated with heart failure are smoking, excessive intake of alcohol, dyslipidemia, anemia, and chronic kidney disease. There is interest in biochemical and genetic markers that are associated with heart failure. Coronary artery disease, and in particular MI, is considered to be the most significant risk factor for heart failure in the elderly. During the past decades, there has been an increase in the incidence of heart failure after MI due to the increased survival after MI. JAJ is especially vulnerable to heart failure because of his poorly controlled hypertension, which increases afterload. Hypertension can lead to left ventricular hypertrophy, which is a compensatory response to increased afterload. Left ventricular hypertrophy is associated with a higher risk of heart failure, especially in younger individuals. The lifetime risk for individuals developing heart failure with BP of at least 160 systolic 90 diastolic is double that for those with BP less than 140 systolic 80 diastolic. Preventive strategies directed toward earlier and more aggressive BP control can reduce the incidence of heart failure by almost 50% and its associated mortality as well. We will now briefly talk about nonsteroidal anti-inflammatory drugs and sodium content. Nonsteroidal anti-inflammatory drugs (NSAIDs) exert their anti-inflammatory effects by inhibiting prostaglandins. Blocking prostaglandins leads to sodium reabsorption and counteracts the beneficial effects of diuretics and ACE inhibitors. Ibuprofen used for JAJ's arthritis contributes to sodium overload. Epidemiologic studies indicate that NSAIDs exacerbate heart failure symptoms, resulting in hospitalizations for heart failure. ACEIs practice guidelines recommend avoiding NSAIDs whenever possible in patients with heart failure. Another potential source of excess sodium is in IV formulations. Sodium chloride is often used as a diluent for IV drug administration. Some parenteral antibiotics, particularly nafcillin and ticagrelin, have high sodium content. Most prescription and non-prescription drug labels carry a disclosure of sodium content. JAJ's hypertension and heart failure are both poorly controlled and he has gained 8 kilograms. His clinical presentation, orthopnea, dyspnea, shortness of breath, lower extremity edema, elevated jugular venous pressure, clearly indicates fluid overload. This could be a result of high-dose ibuprofen use. His hydrochlorothiazide should be replaced by a loop diuretic to enhance diuresis. Also, an ACE inhibitor should be added to the current regimen for BP control. Once he is euvolemic, the addition of a beta blocker before discharge should be considered. Lowering the dose or preferably discontinuing all NSAIDs might reduce sodium retention and allow ACE inhibitor therapy to be more effective. Acetaminophen is an alternative for treating his osteoarthritis. Regarding diet, it is possible that JAJ's diet contains a considerable excess of sodium from foods such as canned soups and vegetables, potato chips, or overuse of salt at mealtime. Dietary supplements and sports drinks can also be rich sources of sodium. He should follow a controlled sodium, that is a 2 to 3 grams per day, diet. If salt substitutes are used, he should be warned that they are high in potassium and could cause hyperkalemia if used concurrently with potassium supplements, an aldosterone antagonist, or other potassium-sparing diuretics. The next question reads, what are the basic mechanisms by which drugs can induce heart failure, and how can an understanding of these mechanisms be predictive of drugs to avoid in JAJ? Drug-induced heart failure is mediated by three mechanisms, namely 1. Inhibition of myocardial contractility by negative inotropic agents and direct toxins. 2. Proarrhythmic effects, or 3. Expansion of plasma volume. The latter category includes drugs that act primarily on the kidney, to either alter renal blood flow or increase sodium retention, or those that increase total body sodium and water because of their high sodium content. The most recognized negative inotropic agents are the beta blockers, which decrease myocardial contractility and slow the heart rate. Both of these factors can compromise cardiac output. Other well-documented negative inotropic drugs include the non-dihydropyridine calcium channel blockers such as verapamil and diltiazem, and some antiarrhythmic agents, disopyramide, flecainide, and drornederone. The anthracyclines such as dornorubicin and doxorubicin have a direct dose-related cardiotoxicity that can be minimized by limiting total cumulative doses to 500 mg per meter squared. Cocaine and alcohol are cardiotoxins when used chronically in large quantities or after an overdose. Drugs that increase the incidence of arrhythmias will worsen heart failure if the abnormal rhythm compromises cardiac functioning or output. Drugs that promote sodium and water retention include NSAIDs, certain antihypertensive drugs, glucocorticoids, androgens, estrogens, and licorice. Weight gain, peripheral and pulmonary edema has been observed in patients with pioglitazone and rosiglitazone. Worsening of heart failure appears to be dose-dependent and presumed to be at least partly caused by fluid retention. As a consequence, the package inserts for pioglitazone and rosiglitazone recommend they not be administered to patients with New York Heart Association Class 3 or 4 heart failure and that they be used cautiously in earlier stages of heart failure. Saxagliptin has been also associated with an increased risk of heart failure hospitalizations. The FDA has initiated an investigation to further evaluate this risk. The next question reads, what are the therapeutic goals in treating JAJ? Cure is not a feasible therapeutic objective in patients with most forms of heart failure, exceptions being patients who are candidates for cardiac transplantation or who have certain forms of viral, alcohol-induced, or tachycardia-induced dilated cardiomyopathy. The immediate objective for JAJ is to provide symptomatic relief by reducing his complaints of shortness of breath and paroxysmal nocturnal dyspnea, improve sleep quality, and increase exercise tolerance. Parameters to measure success include reduced peripheral and sacral edema, weight loss, slowing of the heart rate to less than 90 beats per minute, normalization of BP, reduction of BUN, reduction of heart size on chest radiograph, decreased neck vein distension, and loss of the S3 heart sound. Long-range goals are to improve JAJ's ejection fraction and quality of life, including better tolerance of daily life activities, fewer future hospitalizations, avoidance of side effects of his therapy, and ultimately, an increased survival time. The achievement of these goals depends on the severity of JAJ's disease, his understanding of his disease, and his adherence to prescribed interventions. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 292.